Hi, I'm Dr. Hagop Kantarjian from the Leukemia Department at MD Anderson Cancer Center. What I'd like to discuss today is the major progress and the therapeutic breakthroughs which are happening in adult acute lymphocytic leukemia. So as you know, historically, with the long-term dose-intensive chemotherapy regimens, which cure 80+% of children, we have reached a plateau of a cure rate of 40 to 50% in adult ALL, and that includes patients only up to the age of 60 years. Now, I think there are many things which are happening which are going to revolutionize the treatment of adult ALL in the next 5 years. I'm going to start first with Philadelphia positive ALL, and this subset includes about 25% of the patients. And here, the introduction of the third generation tyrosine kinase inhibitor, ponatinib, to chemotherapy has improved significantly the cure rate in these patients. We have treated over 100 patients, and we have a universal complete response rate and a complete molecular response rate of about 85%, which allows us to avoid the need for allogeneic transplantation. Now, we can do better than this by avoiding the intensity of the chemotherapy or by introducing the new antibodies which are available to us. So what we've done in our current studies is use lower intensity chemotherapy, what we call the mini CVD, together with ponatinib and blinatumomab. And we are also investigating a non-chemotherapy regimens of ponatinib with blinatumomab and the addition, if needed, of inotuzumab. The endpoint is to achieve a durable complete molecular response and avoid the transplantation. And I think we're doing very well in this subset. Now, the large majority of the patients have the other forms of pre-BALL or the T-cell ALL. In pre-BALL, we have started introducing both inotuzumab and blinatumomab to the frontline chemotherapy, and we're seeing excellent results. Now, one issue to discuss here is the use of the pediatric-inspired regimens versus the hyper-CVAD regimen in patients up to the age of 40. And there are many programs which are adopting the pediatric-inspired regimens that utilize a lot of asparaginase vincristine steroids, essentially the non-myelosuppressive drugs. But such regimens have to deal with the toxicities of the asparaginase. The hyper-CVAD is actually a pediatric-inspired regimen in which we have removed the asparaginase from the frontline therapy, and we are using more myelosuppressive regimens. With these studies, what we found is that the hyper-CVAD gives equivalent results to the pediatric-inspired regimens in patients up to the age of 40. But the hyper-CVAD can be used much easier in patients up to between the age of 40 and 60, and the attenuated mini-CVD can be used in people over the age of 60. So we have designed a regimen of the mini-CVD blinatumomab inotuzumab, which we tested in the salvage setting at the beginning. And in salvage 1, we have a complete response rate of 90%, which is as good as the frontline therapy. And we are seeing a 3-year estimated survival of 40%, which is fantastic. So then we took the mini-CVD inotuzumab blinatumomab regimen and started using it in people 60 years and older. And again, what we have observed is the regimen is very well tolerated. There is no induction mortality because we're using the lower intensity chemotherapy. And we are achieving, again, almost a universal CR rate of about 95%, a very high complete response rate with MRD negativity. And the estimated 5-year survival with this regimen is now slightly above 50%, which is as good as what you get with the intensive chemotherapy regimens in the adult ALL historically. Now, because both the pediatric-inspired regimens and the hyper-CVAD ofatumumab produce a potential 5-year survival of 60% in people up to the age of 40, we decided that it will be too risky to use the mini-CVD. So we took again the full hyper-CVAD regimen. We added the inotuzumab and blinatumomab, and we're testing it across all age groups up to the age of 60. And we have very good positive results. So my view in the future is that the treatment of adult and older patients with ALL is going to be with much less chemotherapy and with the addition of those new antibodies. And perhaps then we can redefine the role of the CAR T cells in salvage 2, perhaps in salvage 1 if needed, and also perhaps as a replacement to allogeneic transplantation in patients in first complete remission. So I think the major breakthroughs in adult and older ALL are the addition of the third generation TKI ponatinib to either antibodies or to lower intensity chemotherapy. And this is in Philadelphia positive ALL. And then in the other ALLs, I think the new antibodies targeting CD19 and CD22, when we add them to the chemotherapy with much less chemotherapy, we're producing fantastic results. Now, in the future, we're going to see if new drugs such as venetoclax and some of the other investigational regimens such as the menin inhibitors will further improve the outcome of patients with acute lymphocytic leukemia.